Well, it's a true pleasure to be with you this evening. It's just getting evening time here in London, and I'm talking to you from central London. It's a great shame I can't be with you. There were plans for me to come and work with some of you at your annual meeting, but they got changed because of COVID-19. But anyway, I know you're having a really intensive session on high intensity focused ultrasound, and I want to share with you some of my experience and thoughts on it, and actually some of the emerging literature that is just recently in the public domain, which I think will help you considerably in advising and treating your patients. So obviously, HIFU is just a way of selectively treating bits of prostate. See if I can advance that. And it allows many men to have a tissue preserving therapy where otherwise they would have to commit to either surgery or radiotherapy. So what we do by that, we expand their therapeutic options, we treat their cancer, and I'll show you the degree to which we can do that. But at the same time, we make a really good attempt to preserve genitourinary function in terms of voiding, and that's preservation of continence, a low or even lower IPSS score than at baseline, and obviously preservation of erectile function and, if possible, ejaculatory function. And you can see that this individual here with a lesion seen on this really ancient MRI scan, it's nearly 20 years old now, you can see that the MRI gives us the location of the disease, which is then confirmed on biopsy. And then we use the negative predictive value of the other parts of the prostate in order to define what we treat and what we don't treat. So this has largely become an image-based therapy that we undertake. And obviously the MRI, the biopsy, is an important part of the risk stratification and case identification, but HIFU is a key element of the treatment. And more, as I think about this, the care of patients now is dominated by the presence or absence of lesions. In our hands at UCL, if you have an MRI and you don't have a lesion, you don't go to biopsy. So we trust in the negative predictive value, as we have learned to do through the PROMISE study and the precision studies that have been published over the last 5 years or so. If you have a lesion, then you're suddenly at risk because you'll need that lesion monitored. You may need that lesion biopsied, and whether you have it monitored or biopsied, you may need that lesion treated. And so I suspect that the future of cancer therapy, to a large degree, will be the elicitation, in other words, finding out if they're there, and the monitoring of these lesions and the treatment if and when they progress. Most lesions contain Gleason pattern 4 within them, and therefore most are clinically significant by traditional criteria, though they may not be lesions that interfere with the quantity of life if left untreated. We've done quite a lot of work recently on the management of lesions, and this is within an active surveillance community. This is described as a protocol in the paper. It's more of a system of care where we try and get concordance between the MRI abnormality and the biopsy so that everything lines up in terms of cancer core length and likely Gleason grade. And then we monitor those lesions over time as part of an active surveillance protocol. So we're quite comfortable monitoring low volume Gleason 3+4 lesions over time. And this has allowed us to actually elicit the dynamics of these tumors as time progresses. And what's been really fascinating is that the presence of a lesion versus no lesion basically increases the risk of your prostate cancer significantly. So non-visible Gleason 3+3 behaves very well in terms of the event-free survival. Visible 3+3, in other words, 3+3 associated with the lesion, behaves like non-visible 3+4, which you can see here. Visible 3+4 behaves very badly in terms of the freedom from progression. And you can see here, if you have visible 3+4, the average amount of time you're going to spend on surveillance before intervention is going to be relatively short compared to non-visible Gleason 3+3. And obviously, if a visible lesion progresses, in other words, gets bigger over time, they become very eligible for focal therapy. Why? Because we've been watching that lesion for a substantial amount of time, and we're also can be relatively sure that no lesions have developed in the other non-lesion parts of the prostate. So we have some information on the background stability of the prostate. So for focal therapy to work, you need a lesion that's clinically significant that needs treatment, but ideally you've got a patient whose background prostate is relatively stable. And you only really know that by watching. In the future, we may, of course, be able to predict it. So we're learning more and more about focal therapy, and this is our attempt to summarize the literature some time ago now. And I think it's fair to say that the overall quality of the literature then was poor. It's improved a lot since then, largely actually as a result of the papers that have been published on individuals and colleagues using high-intensity focused ultrasound to treat men with prostate cancer, which is the bulk of the data, and therefore forms the bulk of the evidence base on which we make decisions. So what are the principles? Well, I think you're all keen focal therapists. These are very important. You are driven to reduce the margins that we apply to the cancer. The maximum margin is a wide excision or radiotherapy to the prostate and pelvis. This is an attempt to reduce the margins. We're also passionate about individualizing treatment. In other words, we are prepared to treat everybody differently rather than everybody the same. Historically, radiotherapy and surgery has been a one-size-fits-all policy, irrespective of grade, tumor volume, location, etc. We also want to improve the therapeutic ratio. So we want to maximize the benefits and also reduce the harms. And that's what's been happening in other cancers. So if you think about other urological cancers, excuse me, we used to do radical nephrectomy, now we do partial nephrectomy. When I was training and somebody had penile cancer, we used to remove the whole penis and create a perineal. These patients used to pee then through the perineum. Now we use imaging to try and preserve as much tissue as we possibly can. And I think it's always worth reminding urologists when speaking to urologists that urologists have always innovated very well and very ably. We've been very good at inventing new ways of treating old disease. TURP was a fantastic invention. Ureteroscopy was a fantastic invention for kidney stones. So we've been very, very proficient at working with industry and working with technology to come up with much better treatments that are better tolerated and favored by patients. So focal HIFU is no different to the traditions that we've historically seen in our profession. As you all know, there are a range of technologies that can be used to selectively treat prostatic tissue. Most of them use extremes of temperature, which is how HIFU works, of course, through the kinetic energy associated with the sound and the sheer concentration of that energy. We managed to increase the temperature to 60 degrees for 3 minutes, which is the minimum that we require to treat all carbon-based life form. So there shouldn't be a cancer grade that can survive 3 seconds of 60 degrees, provided we can get to that and sustain it for the 3 seconds. The challenge is to get the energy to that area. But other ways of doing it, high voltage current, high dose radiotherapy, laser treatments, toxic injection has been tried, not been that successful because the prostate is full of ducts and the injection dissipates throughout the prostate. And there's been an attempt recently with cancer selective treatments that usually are complex treatments that involve nanoparticles to rest in the cancerous tissue through the abnormal vasculature and then superimposing some form of initiation of those nanoparticles. And I think it's fair to say that currently there are examples of all those either being tested in clinical trials or being used. So the eligible patient is a man with a discrete lesion on MRI with clinically significant prostate cancer. The lesion has to be in a part of the prostate where we can apply a decent margin. If we can't apply a margin, then our risk of getting a recurrence at the edge of field increases. And so operating very close to the sphincter, very close to neurovascular bundles, very close to the bladder neck can be problematic in some cases. So this is an important part of case selection. We want to preserve genitourinary function. We want all our men to go home continent and potent. Now, it's not possible to achieve that in 100% because we don't live in a perfect world, but that should be an aim. And I think we're also keen that our patients are aware of the uncertainties surrounding treatment. There aren't many uncertainties left with HIFU now. We know the short-term outcomes, we know the medium-term outcomes, we know the side effect profile, we know the toxicities, we know the kind of range of complications that patients might suffer. Fortunately, they're few and far between. I think the only real uncertainty are the long-term outcomes and actually the likelihood of developing a second tumor over time between 5 and 10 years. And I think also patients need to be aware of the salvage strategies. We didn't really know much about how patients would behave when exposed to a second treatment. That could be a second HIFU, it could be radiotherapy, or it could be surgery. But as you'll discover, we are learning more and more about that. And I'll share a very recent paper that we published on that, because that's often been an objection to focal therapy in some of these individuals, that it will compromise care downstream. So this is our HIFU story, and it's been a really interesting one, and it's one that has been developed over time by doing what we could do, what was reasonable to do, what we were allowed to do ethically and scientifically. And actually, it's also shown a maturity in terms of how we understand the disease. And we started off doing an anatomical treatment, which was a hemiablation in men with disease on that side and no disease on the other side. This has merits because it's easy to do. Everybody can understand where the midline is, and it's fairly easy to follow up. And I'll give you an example in just a second. However, it takes a long time to recruit to studies with this, and it renders a lot of men ineligible, because the majority of men who've got a significant disease on one side of the prostate will, if you look hard enough, have 1 or 2 millimeters of Gleason 3+3 on the other side, particularly as we did then, that you were sampling men with 5 millimeter template prostate mapping, which would mean biopsying men 40, 50, 60, sometimes even 100 times. That study was published, and many of you will have read it. We then got a little bit fancy, and this is with the onset of MRI. So we could see the tumor, and just like in other cancers, we thought we could treat the cancer with a smaller margin and not have that redundancy of treating a whole lobe. And this is interesting, and it's a departure from an anatomical treatment to a treatment that is based on the lesion itself. So defining the morphology of the lesion in cross-sectional area and also longitudinal Z-plane was critically important. We then got even fancier, and obviously this is time has elapsed, we're getting better at it, imaging is improving, biopsy strategies are improving. We got to the point where we would treat any cancer we identified. So we would expose men to more than one treatment to treat all measurable disease. And that meant that we could actually include more patients than we could in these first two categories, where the rest of the prostate had to be pristine, both on MRI criteria and also 5 millimeter template sampling. And not many men are, actually. And then we kind of grew up, and then we realized actually that Gleason 3+3 is a non-lethal entity. It doesn't metastasize, nobody's died of it. And starting to entertain the idea whether cancers are born bad or become bad. And so we said, well, if we can't reliably identify it, if it's there anyway, why don't we treat the disease that we know to be associated with a reduction in life expectancy or an increase in premature death, whichever you prefer, and then just monitor disease that probably doesn't matter. And this meant that actually most men were eligible for focal treatment. Most men have an index lesion with a couple of bits of Gleason 3+3 on the other side. And you can see this transition from being very, very tight about what we allowed in to being a little bit more permissive in terms of allowing multifocality. We don't yet know whether multifocality predicts an out-of-field recurrence in time. You would think that it would. Some Gleason 3+3 is going to morph into Gleason 3+4. When you've had focal therapy, you'll keep a very careful eye on the prostate with PSA and sequential MRIs, so you should pick it up if it occurs. This is the future, and so this is treating the index lesion that you know to exist, and perhaps permitting the observation of a lesion that's more than Gleason 3+3, and I've treated many men like this. So what we're talking about is low volume Gleason 3+4, which is very, very easy to diagnose now, as the likelihood of attributing a little bit of secondary pattern 4 is increasing and has increased with time. It's probably increased by about 20% in terms of reporting without any change in the underlying risk. And this is really just to put the notion out there that we might be willing to tolerate out of field more significant disease by the use of adjuvant therapies, or by future risk stratification in terms of, germline genetics, etc. And so here we're thinking about low dose radiation as we use in the breast, or maybe something like finasteride or dutasteride to kind of calm down the background prostate. So this is essentially a kind of research question. And there's a good example of research that you can do to help us progress this field. A lot of critique is directed at us for treating disease that doesn't need to be treated. In our index study, which is now over 10 years old, you can see published in 2010, there were only 10% of patients that had Gleason 3+3 in that study. Most men had, either dominant pattern 4 or secondary pattern 4. These days, we hardly treat anybody with Gleason 3+3 as the primary source of treatment. So there's no question that focal therapy with HIFU treats or should treat men who would otherwise need radical treatment. This is not a substitute for surveillance. I think surveillance is surveillance. This is a substitute for radical treatment in men that are eligible. And here's such a case, treated a long time ago now. We're still seeing him in clinic. Big tumor on the left-hand side, you can see there. The image quality in those days wasn't what it is now, so apologies. He had a left hemiablation in the study that he was in. And you can see that the rectum is beautifully preserved here. The whole left side has been treated. And the neurovascular bundles remain perfused, both actually on the untreated side and also on the treated side, you can see here. And then 6 months out, you can see that necrotic tissue contracts to 3 or 4 mils of tissue. And that's what we watch over time with sequential MRIs. And we want it to stay dark on the T1 gadolinium and not have any perfusion within it, and certainly not return any abnormal signal on the diffusion characteristics. Just worth noting that as the prostate shrinks asymmetrically, you can pull up a little bit of rectal mucosa. So when retreating the prostate with HIFU, it's important to note that the anatomy will be slightly complex, and much of this treated tissue won't return much signal because it's very smooth, homogeneous scar tissue, so sound waves tend to go through it. And so what's remarkable about the HIFU literature in focal therapy is just how consistent it has been. And most people have reported similar results to this. Most people are continent. About 85 to 90% of men are free of disease at whatever time point you measure it, between 1 and 5 years. And about 90% of patients keep erections sufficient for penetration, largely dependent on their status before treatment. And it doesn't matter where you go, who's doing the treatment, what their case selection has been, because it's going to be different everywhere. Those are the results that you get if you stick to the kind of plan in terms of case selection that I'm sharing with you this evening. And as some of you will have seen, this is the result of one of our studies. Not to say that we are unique or extreme. These are the results that everybody's getting. Most men will get their continence back. In fact, all men in this study, by whatever definition you choose, most men will get their erections back. And about 85 to 90% of patients will be free of disease at their point of evaluation. So this is just to give you some more detail on sexual function using high intensity focused ultrasound. So here we combined 3 HIFU studies that we did, in about 10 years ago, 8 years ago, and maybe 7 years ago. And so these are all prospectively collected, registered studies in which we collect the data very, very formally. And suffice to say that it's really very hard to show a difference in erectile function a year after treatment compared to baseline in terms of overall IIEF score. And again, you can see it here. So base overall IIEF, again, from baseline to 12 months, very, very little difference. What you do need to tell patients is that a large proportion of patients, about a third of patients, will end up using Viagra or equivalent, or tadalafil 5 milligrams once a day, in order to help them restore erections. Many patients don't have perfect erections at baseline, are using medication, and will continue to do so. And men will have a relatively low threshold for using it in the post-treatment phase. So I use this as part of my consent and tell people that they have about a 1 in 3 chance of needing some form of medication, which may not be forever. It may just be to get their erections back over 6 to 12 months. I do tell them that if after 12 months the erections haven't come back, then age takes over, and other comorbidities may actually drive things, and that it's unlikely that the erections will return without doing something major, such as injection therapy or an implant. This is not HIFU, but just to show you that we do have randomized data. I don't have any randomized HIFU data to show you, and this just exploits the randomized design to show you, and in this study it was a hemiablation. This is the STIBA study that we reported some time ago, just to show you how well focal therapy can be tolerated. And HIFU is no different to this. It's just that in this one we had a randomized study versus active surveillance, and erectile function and IPSS were essentially identical, with a hemiablation, and I've just shown you a HIFU hemiablation and a vascular targeted hemiablation, and they're very, very similar. In fact, the end result is the same, but there is no difference compared to active surveillance, which is really quite extraordinary. And that's amazing when you compare sexual dysfunction following surgery, for the last 10 to 20 years. And whereas despite all the improvements in surgery, robotic, etc., despite all the improvements in medication, despite the general more healthiness of the population that we treat, the erections have not improved if you have surgery. The only way to improve erectile function in men having prostate cancer treatments is to treat less tissue. So focal therapy is the answer. And again, showing you exploiting the randomized design here. So huge efforts to randomize, which means your baseline risk is the same in both groups. That the grade 2 toxicity was slightly greater in the treatment arm, as you would expect. It is in HIFU. Put a catheter in, treat the prostate. It's going to cause some short-term effects, but it was really important that there was no difference in the kind of severe or the high-grade complications that you might see afterwards in a completely balanced set of individuals over time. So what can we learn from recent study? What kind of failure events are there out there when we're doing HIFU? So I suppose the first question that patients ask if you get a recurrence after treatment, and I tell patients there's an 85% chance they will just need one treatment over a 5 to 10 year period, with a 10% retreatment rate during that period. So a second HIFU, which either could be to the original area or to a new lesion. And there's about a 5% chance they'll need either surgery or radiotherapy if we can't control the disease with focal treatment. So the first question is whether failure is residual, you didn't get it the first time, or whether it's recurrent, you did get it and the cancer came back. It's unlikely that there's any intrinsic resistance to heat applied over a period of 3 seconds that exceeds 60 degrees. Now, obviously, if we don't get to the heat, then obviously cancers will survive that. There are elements of HIFU that we need to try and control in order to get the ablative end result that we're after. The prostate moves because the patient has to breathe, and we need to be aware of that. And also we need to get sound energy through the prostate and deposit it exactly where we want it. If we deposit it too far ahead, we miss the area that we're trying to treat. If we deposit the energy in the near field, we don't get to the area. And so the errors that we as operators try and manage or fight or mitigate are impedance. You can't go through calcium, that's case selection. Attenuation, all energy loses some of its momentum as it goes through tissue, other than water. Movement, I've talked about, and the swelling, which inevitably occurs as you heat something up. You stop the blood supply to it, edema will result. HIFU has the benefit of us being able to add treatments as the treatment is ongoing, so we can adjust for swelling. Movement, I adjust for, by redundancy, treating a bit more than I think we need to treat, overlapping the treatment sectors significantly, and also watching the prostate before I start treating, and then asking the patient, asking the anaesthetist to paralyze the patient if the movement is too much. So if there's a real swing in prostate, I worry about that. I worry about the occasional skip lesion. But having said all that, if one does the HIFU as the manual says, you will mitigate those problems. Every energy has to obey the laws of physics, and every energy has its kind of weakness or a little bit of detail that needs some degree of attention. So I think the most important thing is case selection. Make sure that the lesion that you're treating is within 4 centimeters of your focal length. Remember, you need to get anterior to the lesion, so those 4 centimeters need to be generously anterior. Make sure that your patient doesn't have any calcification in the way. Reduce movement and augment the plan as you go along to respond to the swelling. I think over time, when you start out, one is very careful and worries about causing a rectal injury. The way that the machine is configured and the way that we distribute energy in the prostate is a very safe. I mean, I've treated thousands of cases. I don't think I've had a rectal fistula in a primary case. So the risk is, 1 in 2,000 or something. And that's just having confidence in the software and the hardware, but you have to use it appropriately. You have to make sure the rectum is in a low energy area, and you have to make sure that at no point the rectum is being treated. And it's not difficult to do that, but if you do that, you will be safe. Most people that have had a rectal injury, it's because they were treating rectum and didn't actually recognize the fact that they did. Edge of field failure is probably the most common event, and this may relate to us underestimating the size of the tumor. All cancers need a margin treated, whether it's melanoma or brain cancer, because cancer extends microscopically beyond the clinical limits of the tumor, whether that be a visual limit or a radiological limit. Nobody quite knows what the appropriate margin is, but there have been reports of microscopic extension of up to 9 millimeters. So you want to apply a generous margin, which means actually that in most patients you're treating a quadrant of the prostate or an octant of the prostate. It's rare that you treat anything less than that. And I think here there's a kind of balance to be played with out of field treatments. I like to apply around a 10 millimeter margin if I can to the area. Sometimes you have to reduce that a little bit. I think you can apply a tighter margin when you can see the tumor very, very clearly. Diffuse tumors I worry about because you're not really quite sure where the margin of the cancer is and where those margins have to be applied. Edge of field failure tends to occur early. So it normally occurs within year 1 or year 2. So you can spot it early and it's quite easy to retreat. So you're retreating an area that's been treated already. There's very little additional toxicity that results from retreating an area twice, provided you're careful with a rectum, which of course you will be. And I suppose, the more reliant we are on software to tell us where the lesions are, it is possible that there could be a software error telling us that the lesion is here, when in fact it's there, or extends further out than you think. And again, to reduce this risk, case selection is, as always, I think, the most important thing in focal therapy. Case selection, case selection, case selection. Working very close to the apex is difficult because it's just hard to apply a decent margin. And some colleagues are doing biopsies around the lesion just to make sure that there is no microscopic extension around it. I was visiting professor at University of Texas Southwestern, and people there tend to do, they target the lesion but then do biopsies around the lesion. You can make up your own minds about how you do that. I think the new software that is coming out, that I'll show you an example of, is very helpful also in defining what we treat and how we treat it. And here's a picture of it. So this is a left-sided anterior horn lesion, and coupled with a left peripheral zone lesion. They're both sufficiently close to each other to incorporate in one treatment. We're now treating the posterior aspect of the anterior lesion, and almost certainly incorporating the anterior component of the posterior lesion. But he had an anterior treatment. He's having a middle treatment. He may have a second middle treatment. Sometimes I treat, with 4 very closely applied sectors, and he'll have a posterior treatment. But you can see here that the machine-defined margins are telling us just how far out indeed to treat. And this is really helpful in helping to manage the lesion. So if this wasn't there, we would have some notion in our brains of where we were treating, but we wouldn't have a map as clear as this. Out-of-field recurrence, I think, is the most fascinating. We don't really understand yet the determinants of it. If you've had one cancer, you must be more likely to develop a second cancer elsewhere. I still can't work out who is going to develop a second cancer and who is not. I'm seeing patients 10 years after treatment and their background prostate is completely stable. They must have had a stochastic genetic alteration to cause the cancer. I see other patients that I treat, and then within 2 years, they've developed 2 cancers outside the field. They need to transition to whole gland treatment pretty quickly because they have unstable background prostates and need to be protected from new cancers as well as the cancers that pre-existed. For out-of-field cancer, what do we need to do? Well, I think we need more research. I think we need to know why they occur, whether there are genetic predispositions to it, whether there is anything we can do to prevent it happening in the men that are higher risk. But I think the only way to do that research is to do focal therapy. If you operate on all prostates or irradiate all prostates, you end the story. The only way to understand about second clinically significant cancers is to do focal therapy and subject these patients to detailed follow-up. So there are 2 big residual questions that patients ask: is how does focal therapy compare to prostatectomy in oncological terms? And what happens, doctor, if focal therapy doesn't work? And I think they're 2 very legitimate questions that we didn't really have the answer to. There has been no head-to-head randomized trial of focal therapy versus radical treatment, although I believe the Scandinavians are trying to put such a trial together. They're very, very difficult to recruit to because men have strong views about what they want. And most of these attempts historically have failed because once you consent somebody that there's a better tolerated treatment, they pull out of the study. So the first question, how does focal therapy compare to prostatectomy in oncological terms? Well, we've finally got a paper. Now, it's not a prospective study because prospective studies are very hard to do. but it's based on two series of patients. So 572 laparoscopic prostatectomies versus a database of focal therapy that was largely cases treated with HIFU. And so what we did was a propensity analysis. So you match the patients within those data sets. Once you've excluded the patients that don't count, so radio recurrent disease, etc. And your objective is to come up with two completely identical data sets on the key variables that you choose to match on. So each patient will be matched by age, by whether they receive hormones or not, pre-treatment PSA, etc., etc., etc. You can read. Now, you can't match perfectly because you don't have an infinite amount of knowledge of the patients, but we can match as best as we can, and then analyze the outcome. So I think you can see that before matching, the cases were quite different. So interestingly, men that had surgery were much more likely to have Gleason 3+3 than men that had focal therapy. Obviously, that would skew any results. That would favor surgery. PSA wasn't too different. A lot more patients had neoadjuvant ADT, probably to cytoreduce the prostate beforehand. But you can see if you did your analysis based on this, the baseline characteristics would drive behavior. Once you've matched, all the things that matter look very much the same. Suddenly the PSA is identical. Everything else is very, very similar, and certainly not clinically significantly different. The proportion of Gleason 3+3 is the same. The proportion of Gleason 3+4 is the same. The proportion of 4+3 is the same, etc., etc. And this is the match cohort on which we then derive outcomes from. And these are the outcomes. And actually, the bottom line is that there was no difference in terms of failure-free survival between focal therapy, which is 90% HIFU, 10% cryo, and radical prostatectomy. In fact, the focal treatment did a bit better, but it wasn't clinically significant. So failure-free survival over 3 years, 5 years, and 7 years, you can see here, it's 91% versus 86% for surgery, 86% for focal versus 82%, and 83% versus 79%. So it's there. I would just argue that these are very similar results, and actually don't look like they fade with time, which is really really important. Which is a challenge that we get from our colleagues that insist on removing or irradiating prostates in their entirety. So this is very reassuring stuff. And what about the second question? What about what do we do if things fail? So this is again a report of the first prospective study of operating on people who've had focal therapy, and the bulk of these patients had focal HIFU. And you can see the characteristics of the patients. About a fifth of men had 2 HIFU treatments. Men will always choose a repeat focal therapy if they're permitted to, and that's largely for in-field recurrence. Out-of-field recurrence tends to transition to whole gland treatment. And you can see the risk at baseline. So these are, pretty heavy, pretty high risk individuals. Gleason 4+3 in a third of patients, a little bit of grade 5 in 9% of patients. And you can see just how HIFU dominates the model here. Just 1 electroporation and just 4 cryotherapies. So this is really the story of focal HIFU. Post-operative surgical outcomes, just like in active surveillance, if you're treating men who are exhibiting failure, you're going to get worse disease than you get at entry. It stands to reason. And you're going to get higher grade disease. These are nasty cancers that have progressed despite treatment. Obviously, these occur after surgery. These occur after radiotherapy. They occur after HIFU. They occur after cryotherapy. But what's important, I think, is just how well they recovered. And this was a multi-center study. So I think you could ignore the epic profiles that don't matter. So the green one is the bowel. Obviously, we don't affect the bowel function. And the blue one is the hormonal, which, again, we don't affect. But urinary incontinence largely returned to baseline. It took about 9 months to do so, but that's very impressive. So you can salvage these focal HIFU patients very, very well. Men with decent erections at baseline did pretty well, actually, afterwards. They actually did better than men do after having primary surgery, which is kind of hard to explain. But I think says something for the motivation of these individuals. Obviously, if the erections were poor before the salvage surgery, they were going to be poor afterwards. So this is very, very reassuring, both in functional terms, but also in terms of biochemical failure. So you can see that despite having failed, not sometimes once, sometimes twice, and then going on to surgery, the majority of these patients stayed free of disease, way out on treatment. So the summary of this first prospective study is that salvage surgery is safe in a focal context. Most men, all, had complete return of continence at 12 months. Men with good baseline sexual function had a high probability of return, 80% freedom from biochemical failure at 12 months. So these are data that you can speak to your patients about, which I think are much more favorable than men are led to believe when they see the surgeon, who then counsels them about what happens if the HIFU fails. So I'm coming to the end now, and I hope that's been helpful. We've seen a little bit of new data. You've heard some of my views, trenchant views. Focal therapies emerged as a new class of therapy, which I think now commands legitimacy around the world. Most people want to master it and offer it to their patients. I think focal therapies forced a degree of precision in terms of risk stratification that was missing before. Active surveillance didn't change anything. Focal therapy did. I think we're at the beginning of a story in terms of focal therapy. Originally, HIFU was used for the brain in the 30s, then used for BPH. Now we're learning how to use it for really well characterized patients who've got a lesion that needs treating, around which we can apply a margin. To do this well, you don't just need to be exceptional HIFU operators. You need really good imaging. You need a partnership with radiology. You need really, really good obsessive risk stratification. So you've got to really know what's in that prostate. And I think the key is that you don't get any upgrading from biopsy to radical prostatectomy. If you're getting upgrading, it just means that your diagnostic strategy is imprecise. If you're getting upgrading 30%, it means you're getting it wrong in 30% of patients. So upgrading needs to be down to 5% or less, I think, to run a really good focal therapy program. And if you are getting upgrading in excess of 10%, you need to do something about your imaging or your biopsy strategies. You need to be expert at managing the energy, and HIFU is relatively straightforward to learn, but I think it's quite difficult to master. So it requires somebody who's really dedicated and wants to spend time, because it involves some judgment. You're not treating here by numbers. You're watching the tissue constantly. You're changing the energy levels to levels that you think are appropriate. And that takes some time to learn to do well. But fortunately, there are lots of people that have learned the hard way on their own that are more than happy to help you and answer any questions and help you become expert. I think as a community, we need to be committed to long-term data collection so that there are no residual questions left unanswered. And I think actually, increasingly, I believe that a good focal therapy program is the arbiter of a good prostate cancer care program. If you're doing focal therapy well, you're doing everything else well. And so I commend you all. I wish I could see you all, but I commend you all for doing this and for embracing this with such enthusiasm. I would be with you all virtually were I not already pre-booked at a focal therapy conference, which is happening in New York. That's the NYU meeting, which is happening on the Saturday. I'm obviously doing it from home, but giving 5 lectures, not too different from this one. But I wish you a wonderful evening. I'm always available to answer questions. I'm happy for you to use my email if you have any questions or queries, or want some advice on how to manage these patients. Many thanks for listening to me, and enjoy the rest of the evening. Bye-bye.